Introduced in October 2018, the Health Service Contribution is part of government's strategy to better finance the operations of the Queen Elizabeth Hospital. Despite receiving approximately $150 million each year, it really costs around $180 to $190 million to run the QEH annually, according to Chief Executive Officer Dexter James.
So we see the health services contribution as first an acknowledgement that the package in fact costs almost close to $180+ million, and therefore it provides supplementary funding for the Queen Elizabeth Hospital. This will certainly assure us better operational planning, which will allow us to meet our commitments to our trade creditors on a timely basis, and allow for better operational planning. We can now plan the way we want to execute services. We can now decentralize our budgets to line managers, and in fact hold them accountable for the delivery of a package of services. These funds are dedicated and earmarked funds that will come from the National Insurance Board. Those funds will be transferred to the Queen Elizabeth Hospital as a restricted fund. Our board will then decide how we're going to utilize those funds. But given the fact that it comes as an earmarked set of funds, our intention now is to use those funds to finance the operations of the hospitals in areas where we're vulnerable. And our vulnerability lies in our ability to procure drugs and medical supplies on a timely basis, meet plant maintenance. Those are the areas we're going to focus those funds on. So it allows for a lot more strategic planning in a real sense, because then we now have the option to utilize those funds as the board sees best fit to ensure that we could sustain the services to the Barbadian population.
Dr. James cautioned that the contribution should not be seen as a cure-all which will solve the public health financial concerns.
This is only a fix to address the Queen Elizabeth Hospital and its shortfall. But once we evolve to a model that looks at health financing of our public health services, this will call for much greater conversations. Because the conversation really is not about the Queen Elizabeth Hospital. The conversation really is about prevention in our primary care setting. Again, you have seen in the pronouncement by the Honorable Prime Minister that there are moves afoot to extend the hours at our polyclinics. Yet another initiative that we strongly endorse. Because what that will do is that a number of the primary care interventions that we see here at the hospital can now be seen at the polyclinics. Our E&E department sees about 40,000 patients per year, and just about 26% of those patients are patients who present with non-urgent or non-life-threatening circumstances that require diagnostic investigations.
And in keeping with government's effort to be more efficient, several fiscal and administrative measures have been put in place.
Our board has embarked on reviewing our fiscal financial management processes. That entails looking at our materials management processes, how we procure items. We are now seeking to issue tender for the supply of goods and related services. We've in a sense reduced or eliminated overtime arrangements. In cases where in the past we used to have persons act up, we've sort of minimized that to almost elimination. The payments of terminal pay to officers on contracts, we've in a sense eliminated that as well. But perhaps more importantly, there are new fiscal reporting requirements by state-owned enterprises in keeping with government's BIRD program. We're required to report to the Ministry of Finance by the 5th of the following month. And that in itself has caused us to re-engineer how we assimilate our financial transactions, because it means we could no longer be in a lag mode. We have to be in a lead mode to make sure that we in fact book expenditures in the time frame in which they have occurred.